Today we will talk about the diseases of bones and joints in general practice. This point is very important because the diseases which you see in the hospitals are going to be different. And unfortunately, most of you were trained in the hospitals where you have seen hospital illnesses you have seen. Now after finishing your MBBS, you want to become a general practitioner, but you have not been shown the diseases of general practitioner. So somebody has to teach. In fact, in United Kingdom, they have now put 1 year in the MBBS course for teaching diseases which you see in general practice, private practice. The difference is this, that if you practice what you have learned in the college, you will be overdiagnosing. For example, a disease, you will think of multiple conditions. You will think of extensive investigations, and things will go wrong in private practice. In private practice, you have to only think maximum 3 causes of any complaint and minimal investigations and make a diagnosis. This is the difference between diseases which you see in private practice and the hospital practice. Similarly, the instruments or the tools which you use for diagnosing a patient, which you learn in the medical college. For example, stethoscope. Stethoscope is a tool only for hospital patients, only for hospital practice. Stethoscope is very useful in hospital practice, day to day, every patient when they examine. But in private practice, stethoscope has got no role at all, except to show you when you put it around your neck that you are a doctor. In private practice, we use different types of tools. And over the last 35 years, I have been showing every year 100 tools which a GP must have to examine a patient and make a good diagnosis. And these 100 does not include stethoscope. Maybe one of these days I will be taking a lecture on this 100 tools. But today, the only tools which you will see in bones and joints will be the hands. The hands are tools. I will show you finger in examination of sciatica. It's a tool. So, private practice, the tools are different. Hospital practice, the tools are different. And then we come to the investigations. Most of the doctors, GPs, the knowledge is good, they make a good diagnosis. They go wrong moment they ask for investigations. For example, pain in the neck, you see X-ray cervical spine, you ask for. He'll show you spondylosis. The patient gets upset. The spondylosis I had 3 years back, I was cured. See, the patient does not understand that what is comorbidity. Now that corona disease has come, the public has understood what is comorbidity. They have understood if you are fat, more chances of dying. If you got diabetes, blood pressure, more chances. That means the comorbidity word now the public has understood. But the GPs are still have to be good in that. In my opinion, a good GP is the one who knows the full comorbidity of his patient. Once you know that, your treatment can be much, much better. In fact, one of these lectures I will be taking in future will be on comorbidity. And then the investigations. The GPs have got this habit of asking for blood tests. I mean, patient says, I've got pain in the hand, X-ray for the hand and the blood test. They don't examine. Like in foreign countries, they're doing the same thing. The blood tests are always misguiding. Remember that. One of the most important blood tests which is guiding and not misguiding is an ESR. But I don't take ESR as a blood test. In my teaching, the ESR is one of your tools. I show that machine, the stand of ESR, Western Green. Every GP has to have this tool in the clinic because it's a simple test. You draw that blood, put it in the bulb and suck the blood and put it on the stand and see the reading after 1 hour. And I can assure you, the reading which you will get after 1 hour will be better than any laboratory, the topmost laboratory in the city. Why? Because you are seeing the ESR immediately. ESR should be examined within 4 hours of collection of the blood. It's such a useful test. ESR will save your wrong diagnosis. ESR will save you. It's a very important test. There is no question of that. But when you talk about the other tests, for example, in bones and joints, rheumatoid factor, the GPs are mad after rheumatoid factor and so impressed by this report, the rheumatoid factor is positive. First of all, not many laboratories do nephelometry method, which should be done to look for rheumatoid factor. But in my opinion, that rheumatoid factor is a useless test for diagnosing rheumatoid arthritis because as you grow old, 20-30% patients will develop a rheumatoid factor in the blood. So it is going to misguide you. The only test for rheumatoid arthritis is anti-CCP test. But anti-CCP test, the trouble is, it develops sometimes after 2 months, 3 months, and you can't wait for it. As I'll tell you later on, therefore, even that test in general practice will be misguiding. It comes negative, you think there is no rheumatoid arthritis. There is another test which misguides the general practitioners, and they are highly neurotic about this test, the GPs, and that is blood uric acid. One of the most useless tests, in my opinion, because you send it to 2-3 laboratories, there will be different reports. So, moment they see uric acid 7.9, 8.2, the diagnosis changes. Oh, these symptoms are due to uric acid. And I want to tell you, I want to assure you, high uric acid is extremely common in the normal population. It is as common as high cholesterol, let's put it that way. And it does not produce any symptoms at all. It's only 5% patients who have high uric acid, they will develop gout. And therefore, the treatment of all these patients who have high uric acid is like cholesterol, it's the same thing. Reduce weight, start exercise, no alcohol, no tobacco. So usual treatment, not the uricosuric drugs. There is another blood test which the GPs are very fond of and which will change the diagnosis, and that is vitamin D. Vitamin D is one of the most useless tests at present in making a diagnosis. The reason is this, that vitamin D is rampant, is low in the whole population. Even in the farmers in Punjab who work in the sun whole day, vitamin D levels are low. We don't know why. Therefore, a low level of vitamin D, for example, and so often less than 10. Now, vitamin D, good vitamin D should be about 30, 40, 50. So, a low vitamin D should not make you change your diagnosis. At the same time also, a low vitamin D does not mean osteomalacia, as we will see later on today. For osteomalacia, you should have A PTH reading, unless you have a PTH, the reading of vitamin D cannot be read. I mean, you tell me the vitamin D is 5, I cannot interpret. But if you tell me PTH is parathyroid hormone, PTH, and your blood level of PTH is normal, then I will know, yes, it's just a routine finding of low vitamin D, there is no disease. But suppose I find the PTH is very high, then I'll say this is osteomalacia. So unless you combine the two tests, which again becomes very more costly, the reading of vitamin D will be misguiding. There are some other blood tests which I want to tell you now, because as we go on today, I will be telling you about the drugs of rheumatoid arthritis, and where you have to do every 3 months a checkup for liver, kidney and the marrow. If that is so, every 3 months you don't have to ask for 12 tests for liver, 10 tests for kidney. No, one test. Please remember, as a good family doctor, you are supposed to know what is cost effectiveness. You must save the money of your patients, because all these blood tests are so costly. So suppose I tell you, you are on this drug, check to your liver every 3 months. One test, SGPT, finished. If SGPT is normal, liver is not effective. I tell you, check the kidney, whether the drug is causing any harm on the kidney. Only creatinine, only one test, that's all. And suppose I want you to check marrow. Is the marrow being affected? CBC, RBC, WBC, platelet, finished. You don't need any more tests at all. Don't ask for extensive blood tests where the cost goes very high. Finally, before I start the lecture of the bones, I want to tell you that don't underestimate 3 things. Don't underestimate, especially in view of the bones and diseases, bones and joint diseases, don't underestimate physiotherapy. Physiotherapy is the treatment for most of the bone diseases. And abroad, if you go, you will see that it's extensively done. In our country, the trouble in our country is that it's not so promoted so much. With the result, the people they're charging 1,000 rupees, 2,000 rupees per visit for physiotherapy, which becomes difficult for the patients to pay. But don't underestimate it. It is the best treatment for many bone diseases. Similarly, acupuncture. If somebody says they want to do acupuncture, don't discourage them and don't say it's useless. No. In a country like China, all the diseases of this, they're being cured by acupuncture only. So why should you underestimate acupuncture? If patient can afford, he has got, promote it. Nothing wrong in that. And finally, most of you should understand the passage of time, the value of passage of time. In all bone and joint diseases also, when patients become all right because of the passage of time, not because of your treatment. And of course, overestimating. Many of you overestimate, for example, your drugs that you giving to the patient. Wrong. You think the patient became all right because of your strong tablet? No. Maybe he became all right because of passage of time or some other physiotherapy. So don't overestimate the value of drugs, especially in bones and joint diseases. You're making the pharmaceutical industry very rich, but what about you? Remember one thing, you record the pressure is high, you diagnose hypertension, prescribe a tablet. No, wrong. Moment the pressure is, because that patient is 35, 40 years old, you want him to take the tablet for 40 years if he lives till 80 and spend thousands of rupees? No, wrong. Moment you see high pressure, you tell the patient, lose 10, 15 kilo weight, start doing exercise, Change your diet means no papad, chutney, char, pickles, etc. No alcohol, no tobacco. Start doing regular exercise. Wait. What is the hurry? Wait for 3 months, 4 months, till he does all this. After all this, you want to start the tablet. Well, let us start the diseases of bones and joints. And first, I want to discuss the diseases which are most common, which you are going to see every day. And I am telling you, whether you have got large practice or small practice, you are going to see these illnesses every day. And remember that if you are not seeing these diseases, your patient must be having this as a comorbidity. So we come to the first slide, where especially elderly people, especially females, all the elderly females coming to your clinic must be having all the three illnesses: osteoporosis, osteomalacia, osteoarthritis. Maybe very little, maybe silent, maybe as a comorbidity. But this osteoporosis, osteomalacia, osteoarthritis are so common that in an elderly patient, 75 years old, she is bound to have all the three. It is you how you pick them up. It is you how you attribute the symptoms to which one of these three illnesses. There lies your clinical acumen. And the beauty is that osteoporosis is a silent disease. It produces no complaints at all, which is dangerous. It is like cancer. That the cancer is silent, osteoporosis is silent. And when it does produce a complaint in your lifetime, the first complaint will be a drama, in the sense that patient breaks his leg or her leg. The leg is broken, the hip is broken. The patient has to go to the hospital for an operation. Major operation is done. 4-5 lakhs rupees are spent. The operation is successful. But after 10-12 days, you hear the patient dies. Why do they die? 12% death rate. 12% death rate of the surgery because of comorbidity. So, it's not a very good disease. When you come to osteomalacia, it's the easiest disease to diagnose. Easiest to diagnose. Because it's a very noisy disease. There is a lot of pains. You see, your whole body is ultimately made up of bones and muscles. Your heart is small like that, your liver is small, your brain is small, kidneys. The main body is muscles and bones and joints. Now, you can imagine these patients get pains in all the muscles and the bones. So pain there, very noisy. And yet the disease is due to vitamin D deficiency. We'll discuss it later on. While third disease, osteoarthritis, ideally it should be called osteoarthrosis, is a disease where everybody is going to get it when you grow old. And it's going to increase as you grow older and older. And the symptoms of this, which is pain, has got this good and bad days. Some of the days are good, some of the days are bad. And the disease has got no drugs which can cure it. Chondroitin, glucosamine, which people are using, doctors are using. I don't like to, unless the patient is rich and he can afford to throw away the money. Otherwise, for poor people, don't give glucosamine, because they're not supposed to treat osteoarthritis 100%. And the treatment is not drugs, treatment is physiotherapy. You know, who develops what? Very difficult to understand. So genetics come in there. So maybe the positive family history, you can spot the mother had this, she is going to get this. The important thing which I want you to learn today is this. Many elderly people have got a combination of all the three. All the three illnesses are there in the body. You have to pick up and find out which is more, which is less. And when I say which is less, if vitamin D is low, but there is no pains, then the patient can get their osteomalacia. You can say subclinical osteomalacia. So you start giving vitamin D. The patient does not complain of bad knees, but on examination you find the knees are bad, is crepitus. That is the time you start the physiotherapy. And the patient comes for routine checkup. Any elderly patient, you must ask them. They know their blood pressure, they know their sugar, they know their cardiogram. Ask them, have you got a report of bone densometry? Because unless you have that report, you can't diagnose osteoporosis and start the treatment. So, osteomalacia is preventable, curable. Why? Because it is due to vitamin D deficiency. Vitamin D is present in the sun. Unless you go in the sun, not only that, even if you go in the sun, in elderly people, the absorption of the vitamin D, for example, you see this, I am old and you see the elasticity of the skin. Moment there is elasticity of the skin, there is no elasticity. If there is no elasticity, the vitamin D will not be absorbed from the sun. So that's another point. So elderly people, even if they go in the sun, they still vitamin D deficiency. So osteomalacia is preventable if you give regular doses of vitamin D. Like in America, the bread contains vitamin D, all the bread all over America. Then we come to osteoporosis, which is age and sex. Osteoporosis is not a disease of young people. Osteoporosis is a disease of old people, and especially after menopause. So females, after menopause, osteoporosis starts. Who has got how much osteoporosis? You don't know. There is no signs, no symptoms. You do the test of bone densometry. So, can you prevent it? No. Because you're going to grow old, you're going to have menopause, and as you grow old, the older you grow, the more osteoporosis. Older you grow, and it's not curable. The Queen in UK, Queen Mother had a fracture of the hip due to osteoporosis at the age of some 95, 98. Although she was a queen, not curable. As the age increases, going to be. And even if you have taken treatment, if you fall and break, you can die due to complications of the surgery. While osteoarthritis is, yes, related to age. You don't find it in young boys and girls. After the age of 35, 40, the fatter you are, the earlier it will come. Less exercise you are doing, the earlier it will come. And you get, it's a disease of wear and tear. It's wear and tear of the joints of the spine and the knee. So it is not preventable because you are growing old. It is not curable. So you must learn to live with this disease. All the patients you should tell them. Like your wife, how you learn to live with your wife. She might be having some bad points. She must be having some good points also. Because if you change your wife, you don't know whether the second one who comes might be having more bad points. We'll discuss this later on. So, osteoporosis is dangerous silent disease. The diagnosis is made by bone density. They are machines. And don't go for small machines which only they put on the calcaneum and measure. A proper good machine and you come to know whether you have got osteoporosis or not. The first symptom in the patient who is severe osteoporosis will be the fracture. And this fracture is always either in the arm, forearm, or in the spine, vertebra, or in the head and neck of femur. Please remember that the symptoms of fracture in the forearm are very easy. The bone breaks there, patient can know something has happened, and X-ray shows the fracture. Head and neck, femur also, the patient slips and falls down, and there is a pain, patient can't move the leg, and you know there is a fracture. Spine vertebra is a little tricky thing. That these old ladies of 70s, 80s and all that, even otherwise they have got pain in the back because of osteoarthritis. So when fracture takes place of the vertebra, the pain may be mixed up with that pain. But there could be very severe pain. So the osteoporosis, if you get this 12% death rate. I had this lady in my club, very aristocratic lady and very rich lady and very 72 years old. She used to play tennis with me in the afternoon. And for some time she didn't come. The next I saw her in the evening in the club with a arm in the plaster. So when I saw her arm in the plaster, what? So she started telling me a long story that this happened, I was doing this, I was doing that. I didn't hear the whole story. I only told her, Madam, you have got osteoporosis. She said, what? Osteoporosis. I went to my doctor. He didn't say osteoporosis. I'm telling you, get your bone densometry done. Why? Because if you don't take the treatment, after 1 or 2 years, next you will get the fracture of the femur. This is the story of osteoporosis. That you do this, they are called as DXA studies, bone densometry. And when you do these studies, yes, what you get is a reading. They give you a reading, -1, -1.5, -2, -2.5. And if you have got these readings between -1 and -2.5, then they could be, we call it osteopenia. That means your bones are a little weak. Even in Osteomalacia also you'll find these readings. But moment you find that readings are -2.5, that figure -2.5 or less than that, -2.7, -3, -4, this is all osteoporosis. All such patients you can only give calcium, vitamin D and nothing to worry. But once you get this reading, you have to start special treatment. And that special treatment is biphosphonates. So, when they give you the readings in osteomalacia, osteoporosis, they always give you readings in the spine, readings in the hip, because these are the areas, and the forearm area. They give you 3 readings, that's all. These are the areas which are going to break, not the rest of the whole body, bones and all that. So osteoporosis has got no symptoms. One thing you can pick up, as I said, in this lady I picked up from the fracture. But suppose somebody has lost height. The diagnosis is straightforward, osteoporosis. In my clinic, I have a secretary who takes the height of every patient. Every time they come after 1 year, 2 years, 3 years, again height is taken, weight is taken. And she diagnoses osteoporosis. Moment she sees her previous height of this lady, she had come 2 years back, and now she finds half an inch or 1 inch less, diagnosis osteoporosis. Some of them develop a chronic pain in the back with kyphosis, and then some of them develop this fracture of the vertebra with acute pain, severe pain. And when this takes place, the pain is so severe, the pain radiates through the front. And the pain of a vertebra fracture, it will come from there to here, very severe. Patient is sweating, and the patient sits like that. The patient can't lie down, and severe pain. And imagine a 75 years old lady getting a chest pain in the middle of the night, and the doctor will come. First diagnosis, myocardial infarction. Because 75 years old lady, she's so much pain here and there. That pain of heart also, myocardial infarction, radiates through the back. So the doctor takes an ECG, he sees some T wave changes are always there at this age. Diagnosis, myocardial infarction, patient shifted to the hospital where they diagnose fracture of the vertebrae. So remember this as a differential diagnosis. And I'll tell you a tip to diagnose this. You will notice that these ladies were severe pain, they're sweating, but most always they're sitting, they will not lie down. Tell them to lie down, they will not, because lying down will increase the pain markedly. While a heart attack patient, they lie down, nothing happens, they're comfortable. So, pain in osteoporosis is only when there is a fracture. Otherwise, it's silent disease. And vertebral fracture, like an emergency, can mimic myocardial infarction. And suppose you get a fracture of the vertebra. Most of the time, I would advise you no treatment. The pain will settle down within few days. Only thing is the patient is going to lose height. Now the women in the upper class strata will never accept loss of height. Most, in fact, most of them put on sandals and all with big height to look taller. So there is no question of losing height. So they want some treatment, and the treatment is this vertebroplasty, injecting cement in the vertebra, and so that it comes up. I would not advise you to advise this treatment to all your middle class patients. It's costly. It's not only costly, if the doctor hasn't got enough experience and is injecting cement, you can damage your spinal cord. Remember that. So these people settle down. Some of them, as I said, get very little, not severe pain, and the vertebra collapse, and you will find later on a lateral view of the spine will show you 2 or 3 collapsed vertebrae. In fact, that is the diagnosis of osteoporosis, 100%. You don't have to do even bone densometry studies. But after the vertebral fracture, the height goes down. So, what is the special treatment of osteoporosis? Nothing to boast. In my opinion, the treatment of osteoporosis is very poor. You see, when you give this drug, which is called as alendronate, it reduces the risk of the fracture, which is the main we are trying to treat, only 50%. Only 50%. So, even then, there is nothing. Now, I as a specialist would nowadays give to rich people injection of denosumab. Denosumab is a monoclonal antibody. One injection every 6 months for 3 to 5 years. Each injection costs 15 to 20,000 rupees. I would not advise you to advise to give that injection or prescribe that injection to the patient. Why? Because all these drugs, monoclonal antibodies, their side effects are, when they occur, are bad. Tuberculosis, infections, cancers. And if the patient develops one of them, the patient is going to blame you. Why did you give this? Why specialists cannot be blamed. Specialists can explain that this is the side effect, and all right, you took it. So I will not advise you to give that. I will advise you to give everybody this alendronate once a week, and after taking the tablet, patient should stay sitting, not lie down for 1 hour. Why? Because it produces little symptoms of GERD if you lie down. That is acidity. And if you have this acidity, and if the patient already has got acidity, you have to be careful. The incidence of cancer of the esophagus can occur. It's slightly high, not very common, but more in this patient. A very safe drug. It has hardly got any side effects. You give it for 3 to 5 years. Don't send the patient for extraction of the tooth during this period. Because if the tooth extraction is done, they can develop complication called osteonecrosis of the jaw. And this osteonecrosis of the jaw is a bad complication. And next thing is, if you give this drug for more than 5 years, they can start developing fractures of the femur. Not head of the femur, shaft of the femur. It's very interesting. You're giving a drug to strengthen the bone, and it's causing fractures. This is something which you have to accept it, but then only if you give more than for 5 years. Say after 5 years you find the bone density is still minus 2.7, then you will have to continue, and if you continue, this fracture side effect can take place. And the next thing is the intravenous. Fussy people who don't want to take every week, you can take one injection every week, once a year. Intravenous injection of zoledronic acid once a year, instead of taking once a week alendronate. Now, I would not advise you to give this injection once a year, although it sounds attractive. But why? Because see, all these things, when they come, the side effects also are very peculiar. Intravenous zoledronic acid can cause sudden atrial fibrillation or kidney damage. And if the patient develops atrial fibrillation, by chance your patient, she will not spare you as a GP. Your drug has caused my heart attack. When the specialist prescribes, accept it. And then most important, that this drug alendronate, you are giving only to reduce 50% risk. It is not curing osteoporosis. The side effect of muscle and bone pains. And muscle and bone pain. In my language, which is little rough language I use, that this drug you are giving for osteoporosis, it can cause osteomalacia. So your one disease you are treating, causing second, which means what? Calcium and vitamin D is very important, very important. Everybody must get 1000 milligram of calcium, 1000 units of vitamin D, if not maybe 800 units. Otherwise, don't prescribe alendronate. This is what you have to learn. With alendronate, calcium, vitamin D become more important. What is the other 50% treatment of osteoporosis? Prevent falling. Osteoporosis will break your bone only when you fall. Please remember that. Not if you don't fall. Therefore, as you grow old, using a stick is very useful. The older people, 70, 80, 90 years old, they must use a stick, because if they fall, even if you are taking treatment by phosphonates, you are going to break. And the commonest area where they get fracture, they break, is the bathroom. And I call this bathroom as the graveyard of osteoporosis. 90% patients, they get a fracture in the bathroom. And all these top people with the beautiful bathrooms, top bathrooms. In my opinion, all GPs must visit the patient of osteoporosis house, look at their bathroom, see whether which tiles are slippery, advise about the tiles in the bathrooms. Bars, how many bars are there to hold while taking bath? Because this is the most important part of the treatment of osteoporosis, which is 50% treatment. Remember that. Has the bathroom got enough light? There should be more lights in the bathroom. There should be more lights in the whole house in elderly person of 70, 80, 90 years old. Because if there is no light, you will not see the water and you are going to sleep. And you can explain to the patient, if your electricity bill is more, 100, 200 rupees per month, which is only 2000 rupees per year, which is 10,000 in 5 years, as against that, if you slip and get a fracture of the hip, the operation charges are 4 lakhs rupees. Then they will understand. And most important, then regular walking. Why? Because the balance, and there is no drug which can improve your balance. As you grow old, your balance becomes bad. So in China, they have got beautiful exercises for telling the patients, for carrying out, to maintain their good balance. Otherwise, the only other thing is regular walking. If you walk regularly, you are likely to maintain. With all this, I can tell you, see, in our building, once what happened, in the rainy season, the water came in the lobby. So the secretary, very enthusiastic person, he put a block like this, so that the water should not come. But I, who was supposed to be quite fit, was finding it so difficult to cross. And I told them, I said, there are elderly people in the building. You are inviting fracture of the femur. You are inviting wrong. If only you can understand this, that is osteoporosis. Then we come to the second disease, osteomalacia. First, I want to tell you that everybody says very common. The pharmaceutical people will bring calcium, vitamin D, and osteomalacia. It was supposed to be very common once upon a time, when vitamin D levels were not being done in the blood. When I started my practice in 1960 and all that, so all these fat women will come, those Rajasthani women, Gujarati women, with pains and all, difficulty in getting up from the toilet. I used to tell them to take a glass of cold water, cold milk, go to the terrace at 11 o'clock in the morning, sit there for 1 hour, 11 to 12, till the milk becomes hot, and then drink it. The idea was not milk, the idea was the sun. She would get sunlight for 1 hour. That was the best vitamin D. Anyhow, from that, things have changed. Today we have come to the time when Everybody has got vitamin D level done, 1,500 rupees. They know that. And so everybody is taking vitamin D. Everybody is taking vitamin D. With the result, believe me, real full-fledged osteomalacia has become very rare. If any of you gets a typical case of osteomalacia, and which you have to confirm it with the investigations I show you, I am telling you, please ring me up. I am ready to give you 1,000 rupees to see a patient of osteomalacia. So uncommon it has become. You will be surprised. But it can occur. It can occur in all ages. Formerly we used to talk about pregnancy, the childbearing age, breastfeeding age, wrong. Elderly women, because they are all in the house, they don't go outside in the sun, there is no vitamin D. All sexes, male patient can also get, of course, but less than female. So poor and rich both get osteomalacia. The poor get because they cannot afford to eat vitamin D, which will in the special fish and oil and milk product, or they can't afford to. While the rich people get it because they are so rich, and these old women, they want to stay with so many maid servants, they will not go even to the kitchen to bring a glass of water. Why should they walk? The maid servants are there. But what they don't understand is that they are growing old, bones are becoming soft, and there is no sunlight in the house. But osteomalacia is easily treatable. And I want to tell you one thing. If you diagnose osteomalacia, the patient must become cured in 2 to 3 months, 100%. 100%. If the patient is not cured 100%, your diagnosis is wrong. Finished. Look for something else. Look for something else. So, in addition, it's a good advice to tell them to go sit in the sun at least 20 minutes twice a week. So, the symptoms are what? The symptoms are bone pains. Bone pain and tenderness. What is tenderness? You got pain, you're feeling the pain, but I press, you get, oh, this is tenderness. So tenderness is different than bone pain. Muscle pains, all the muscles. But the most important thing, that muscles of pelvic girdle become weak. Moment they become weak, we call it pelvic myopathy. It's very easy to diagnose. You don't have to send to a neurologist. Any person, any woman who after sitting on the commode, she can't get up very easily, has got pelvic myopathy. Simple it is. And in Indian commode, more the reason. She just can't get up. She has to take the support. Any woman who can't climb the steps or come down. Any woman who can't get up from the chair. My advice is, you see in my clinic for example, I've got chairs with different heights. And all these patients who complain of this complaint, all I do is to make them sit on that chair, stand up, then sit on the chair which is low down, where usually their children come and sit, patients' children. Make them sit on that chair. Let her stand up. She will not be able to do it. You have diagnosed pelvic myopathy, finished. And once you have diagnosed pelvic myopathy in a patient like this, diagnosis of osteomalacia is over, finished. There is no other disease which can cause this. The amount of chest pain they get, because chest is full of ribs. You got 12 ribs here, 12 ribs there, sternum there. What do you expect? So all the bone pains and on muscles on the top, muscles also paining. So the chest pains, they go on getting, and doctors go on taking X-rays, cardiograms, normal, everything normal. What they don't understand is that these ribs, when they become osteomalacic, the ribs break like this. They break like this, they tear like this. There is a fracture where only like, it's not like this. This is fracture of the femur, head, of the femur. But if I say there is a bone and there is a crack like this, that is the crack due to osteomalacia. Treatment is very simple. You give them within 2-3 months. They must be cured. You will see now a video. When the patient complains of pain in the chest, and suppose the pain is on the left, how are you going to examine the patient? Anginal pain, heart pain, there is nothing like examination. That pain comes on exertion. When he is walking fast, trying to catch a bus, or when he is taking some weight in his hands and climbing the steps. On examination you find nothing on angina. Angina is diagnosed by the risk factors, that this man is more than 40 years old, he is a smoker, drunkard, overweight, and he has got a family history of hypertension, diabetes, ischemic heart. Those are on examination there is nothing normal. But there are many other conditions which cause left chest pain on the left side or the right, where you have to examine the patient and diagnose. Don't say that no, there is nothing, it is nothing. That if you tell the patient he has got pain and you tell him no, there is nothing, wrong, absolutely wrong. Now I will tell you, suppose I want to examine this patient, he has got pain somewhere on the left side. The first thing I will do is to examine the costal cartilages. Costal cartilages are up to here. Beyond that there is ribs. So I will press that 1, 2, 3, 4, 5 costal cartilage. And if one of the costal cartilages is tender, he gets pain, then that is chondritis. That patient has got chondritis. Chondritis is a very common cause of pain in the chest, and it is like a common cold. It comes, it remains for 2-3 weeks, that pain, and when you press that thing, he is not comfortable. This is one of the causes which could be the cause of chest pain on the left side, very common cause. Second thing, next, you press the pectoral like this. If the pectoral muscle is tender and this is not tender, then the pain is due to the muscle. He must have sprained his muscle while doing some action, or lifting of something, or in the motorcycle, bicycle, right? Something which he is not conscious of, but it is a muscular pain. And I am showing you this pain here, where, mind you, I am not talking about pain, acute pain, which burning pain of herpes zoster, where the patient complains of pain here. Herpes zoster, if it is a pain, within 2 days vesicles come, but up to the 2 days, the patient, when you are examining, he will not like your hand there, touching your hand. He is so sensitive. The moment patient is so sensitive that he does not like you to touch, but here he does not mind. Suspect that he is going to get herpes zoster in that area. Pain is due to that. So apart from that, I was telling you about the muscle. If muscle pain, then this is due to muscle pain. Once you finish this muscle, excluded it, then you press the breast like this on both the sides. If this breast is tender, one of the commonest cause of left chest pain, then he is going to develop gynecomastia soon, and this is the commonest side effect of the drugs, starting with spironolactones. But number of drugs cause breast pain, and all you have to do is to explain to him it is due to the drug. You can omit the drug, change the drug, but that pain is due to breast pain. Now after this examination, you start now pressing the ribs. When you press the ribs, and suppose one or two ribs is very tender, then that could be a crack fracture. especially if you are examining a patient of COPD or you are suspecting osteomalacia. All these women who come for severe pain, if you press in one of the areas here, one of the areas, very tender, it's a crack fracture. And depending on the diagnosis, you treat the patient. Anyhow, if that is not there, then all you do is examine like this, see like this, like this, like this, like this. Number of people have got small neurofibroma. He may have elsewhere also, but may not be elsewhere. Small neurofibroma, you can feel it like a peanut, like a peanut. And if you press it, it's tender. The pain is coming from that small neurofibroma. And of course, if this pain is in the middle here and tender here, xiphoid process, again chondritis of the xiphoid process. And if it is slightly below the xiphoid process, then of course GERD, esophagitis. So I was telling you that in osteomalacia, you get this type of pains of the cracks. Here, the lady is very tender and she complains of chest pains. I was trying to show in the video that these women have these chest pains for which multiple cardiograms are taken, X-rays are taken. They due to crack fracture. And that crack fracture is common in mainly two diseases. COPD due to cough. COPD patient, they cough and then they develop pain, some severe pain in the chest. It's a crack fracture. And this is the second disease where you get these cracks, which can be seen on imaging if you really want to see the cracks, not an ordinary X-ray. And to elicit this crack, you must spend time. What I was trying to show you in the video was that you examine the patient, they got pains, the severe pains, naturally because the rib is cracked. And so you examine the patient to show that that you see the muscle, see the pectoral, see the breast, see the chondritis, and then you explain to them that, madam, your severe pains are because your ribs are cracked. He showed you the piece of paper which I showed you. So that is the diagnosis of osteomalacia. And when it comes to investigations, I would not like you to ask for any investigation. And let me tell you. You know why? Because they're very costly, and because once you do all these blood tests, and then X-rays, multiple X-rays, even the X-rays may not show those cracks. And you might have to do nuclear bone scan to see the hot areas. In the blood test, vitamin D is costly, PTH is raised, very costly, vitamin D proper instead of D3 you might have to do. But if you want to do one test, I would advise you to do serum alkaline phosphatase, just one test. Serum alkaline phosphatase is markedly raised in osteomalacia. So the treatment is large dose of calcium, 1000, twice a day with meals. Why with meals? If you don't take calcium with meals, then the chances of kidney stone markedly increased. Even otherwise, our population, 20%, 15% population has got kidney stones. And they come again and again. We don't know why. You are increasing the chances by taking calcium if you don't take it with the meals. Vitamin D, like 0.5 microgram calcitriol twice a day for 3 months. In 3 months, the patient is cured completely, and then you can give a small dose maintenance for 1 year or even permanently in women, for example. And I can tell you, this disease is rare. If you really get a patient, and I'll tell you, last year I have seen one patient of osteomalacia, and it was a male patient. It was a milk merchant, those wala bhaiya from Goregaon, was owning 100 buffaloes. And this gentleman, putting on dhoti, was one day running on the station to catch the train, fell down, had multiple injuries. He was taken to the hospital, and ultimately he was cured of all the injuries. Time passed, but after 3-4 months, he started getting pains in all the bones, pelvic bones, these bones, later on chest bones there. And every time he got these pains, he would go to the orthopedic surgeons, and they'll take x-rays, they'll do CT scan, they'll do MRI, because he had fallen 4 months back and he had so much injury that time, they could not find out any cause at all. The pains increased. Ultimately, this patient became so weak, he could not stand up from lying. He would sleep on the ground. He could not stand up. On the toilet, he would sit down. He could not stand up from the toilet. So, in this Bhaiya language, what they felt was that Bimari had increased so much that now he could not even, had no energy, which means the next will be, he is going to die. Anyhow, when he came to me, I heard the story. So much pain there, plus these rib pains. And then I made him sit on the small chair, he couldn't stand up. My diagnosis was Osteomalacia, 100%. I got all the tests, and he was rich, so I got all the tests done, including nuclear studies, and typical Osteomalacia. And then I gave him this calcium and vitamin D, and I told him, 2 to 3 months, you are going to be 100% normal. And I told him that you come to see me after 3 months, you will be absolutely normal. And what do you think? He came after 3 months with 6 bhaiyas along with him. All the 6 were the owners of buffaloes in Goregaon. They wanted to see the face of the doctor who cured him. I mean, such dramatic response that the patient is a walking publicity for you. Now we come to osteoarthritis, which, as I said, everybody is going to have. As you grow old, you're all going to get osteoarthritis, either knees, hips, or spine. Commonest is knee. So knee, you get pain. So initially, patient will get some pain when he's climbing the steps or climbing down the steps, walking too much. The diagnosis is clinical diagnosis. You examine the knee, maybe a little crepitus, may not be. This is the time when you have to explain to the patient that this is a wear and tear of your knee joint. This is the time, lose weight. This is the time you start looking after your health. No alcohol, no tobacco, no this. And most important is, this is the time when you start doing physiotherapy to improve your quadriceps. Quadriceps muscle, if your quadriceps muscle becomes strong, this patient of knee osteoarthritis will have a lovely life. For years together, he won't need surgery. And he will be able to walk around with less pain, provided you can make his quadriceps. So muscle, Salman Khan makes biceps muscle very strong with exercise. You are making his quadriceps muscle of the thigh very strong by advising him special exercises. Send him for a physiotherapist every year to see how strong is his quadriceps. That is your main treatment. No painkillers, nothing, because all painkillers will ultimately have side effects. And I told you earlier, they have got good days and bad days. Sometimes they get bad days, and the pain is very severe. The knee is swollen, pain is very severe. This is the time you send them for local injection of steroid. You can give hyaluronidase also, you can give both also. Very interesting that very often the orthopedic surgeons don't like it. No, don't give. Then the operation will become in future difficult. Wrong. I can give you any amount of literature and show you anyway. In England also, every 3 months you can give another injection. So 3-4 times in a year, no question. And moment you give steroid injection, the severe pain dramatically like magic will become less. So please take advantage of this. And then there is a third disease called osteoarthritis. Osteoarthritis is nothing, it's not arthritis. I was telling you before the interval that how rheumatism is in arthritis. This is wear and tear. Wear and tear because God made you straight, and that this is a wear and tear of, and because we are straight walking, the whole load falls on the whole spine from here to there, the knees and the hips. So they get worn out. And these doctors have called it arthritis, as if it's some inflammation or something. It's nothing. It's just wear and tear of this joint. So it will start with age. The moment you become 30, 40 years old, starts. You bring me a 35 years old man in 40, I can challenge you. I'll show him that he has got this disease in his body. I'll take a spine X-ray, for example, spondylosis. What is spondylosis? It is same disease. Different names have been given. So this man, he comes to me and he says, 10 years back I had spondylosis attack and he was treated. Then when I take his X-rays, there is spondylosis. He said, oh, I've still got spondylosis. I was treated for it. I was cured. Not cured. How can you cure? How can wear and tear go away? It is going to increase as the age increases. The only thing is the symptoms of this wear and tear, which is nothing else but pain. They come and go. There are good days, there are bad days. If you have done a lot of traveling, lifted weight, etc., done a lot of bending, anywhere in the house, symptoms will come more. Take rest, etc., they go away. That means it is not a curable disease. This is curable. This is not curable. This is not curable. But this will not kill you like this. You have to learn to live with this, like your wife. If you've got a wife who is irritable, then you must see the good part of it. Otherwise, she's good. Good. Don't marry again. You don't know which is the second one. She may be worse than the first one. So you better learn to live with her. And before I finish, in 3 minutes, I'll tell you how to live with this disease. And where did I learn from? Whatever I talk here is not from the books. My personal experience. And this experience I got from Arab patients. 1970, 75, for 10 years, there were huge number, and I was very famous amongst Arabs because of language. I could speak the language, I learned it very fast. So this Arabs patient, I'll give you an example of this arthritis, of the knees, for example. So this fellow, Muhammad, he entered, I said, Muhammad, dakhal. Muhammad comes, Subha khair, doctor, Subha khair. And I can see his knees are not straight, he's a little bit bending. And then, Ahlan wa sahlan, how are you? Ahlan wa sahlan. And I said, Ijlis, please sit down. So then he sits, Inshallah. I heard Inshallah. So first I thought he is saying good morning to God. First good morning to me, good morning to God. So I kept quiet. Then I asked him, Ashtab, what's your problem? So he tells me about acidity, hamuda, knees, urine board. He's not talking about his knees, He's not talking about his knees. So I get restless. And I ask him, Muhammad, Rukba. The moment I said Rukba, when Arabs, when they lose their temper, you must see it. You can't control them. This man gets up immediately. Doctor, Rukba wadi. Ma, tum habub Rukba. My knees are normal. Don't write any medicines about the knees. He's warning me. I'm surprised. And then after his temper goes down, he again sits down. And then again, Inshallah. Now I understood. That he is getting these pains, and every time he remembers, Inshallah, God, he can tolerate that pain. His pain threshold increases. And he sits down, and so like that, 100 times in a day, and he moves around. Inshallah. I teach my patients, same thing. You learn, whatever is your Bhagwan. If you are from UP and all, Hanuman is your Bhagwan. Hi Hanuman. Go on saying that. That's how the pain threshold increases. No painkillers. Painkillers are going to kill you one day, either with intestinal perforation or heart attacks or paralysis. And third thing I learned from them, treatment of osteoarthritis. 5 times namaz. This Muhammadan asked him, that come Mara, namaz and all. He said, come sir, 5 times. With all these knees, he does his usual namaz, full namaz, you know. Bending, knees, I'm watching. What is this? Physiotherapy. Physiotherapy. Because they do 5 times this, that's the treatment for back arthritis, knee arthritis. We also send them for physiotherapy and tell them to learn to live with this without any medicines unless you're fed up. Then second wife, change the knee. Thank you. So, the patient has to be taught how to live with the disease. A knee joint, give physiotherapy, and he has to learn to live, not complain, no tablets, no painkillers, till the day comes when he'll need surgery. So surgery for knee, if a patient goes, surgeon will be very happy to operate on him. But all you have to remember is that if you do surgery at a younger age, patient is rich, 45, 50 years old, and he can afford 3, 4, 5 lakhs, no problem. But please remember that they might need a revision arthroplasty. Even if the orthopedic says 10 years, okay, 20 years. But the 20 years he'll be only 65 years old. In 65 years old, he needs a second operation, revision arthroplasty. Any revision operations are bad. Our Prime Minister Sardarji, when he was in the chair for his revision coronary bypass surgery, he had to call the surgeon from Mumbai. All the Delhi surgeons were very upset. Why? Because our Mumbai surgeon was famous for doing a good revision coronary bypass surgery. Same story about knee. You ask all your orthopedic surgeons, how many have you done revision arthroplasties? What was the success of that? So, you should avoid revision arthroplasty. Today in abroad, they are talking about people who are needing revision arthroplasty, mean third time. Bad. So, the only way to avoid this is to operate at an older age. The older you are, and of course, this operation can be done at any age, no problem. Whether you are 70, 80, 90 years old, bypass surgery, this operation also can be done. So, postpone it as much as possible. Learn to live with it. So, osteoarthritis of the knees, silent days, good days, and bad days, steroid injection. In the spine, you have spondylosis, lumbar, we call it spondylosis. All I want to tell you is this, that it causes pains in the neck, in the back, commonest cause osteoarthritis. I only want to tell you one thing. Osteoarthritis is very common. Everybody is having it. Don't overdiagnose and miss some disease. For example, there are 3 diseases which you can miss with backache patient. Number 1, tuberculosis. TB of the bone amongst all the bone tuberculosis, the spine tuberculosis is the commonest. And an average X-ray can miss it. How will you pick it up? Will pick up by ESR. So I told you, ESR is your savior. If the patient has got backache, which you are thinking due to osteoarthritis, and the ESR is 65, 70, diagnosis is wrong, pain is not due to osteoarthritis, the pain must be due to tuberculosis if he is a young person. If he is a young person. If he is an old man, elderly fellow, then must be cancer deposits in the bone which are missed in the X-ray. X-ray can never pick up. Cancer deposits are diagnosed only by nuclear medicine studies or MRI. So, if you don't want to miss this, once the ESR is high and the person is elderly, next thing is a blood test of PSA. Once the PSA is normal, the secondary deposits are, because that's the commonest cancer in males we are talking about. So don't get caught in these illnesses. And the third illness is this, spondyloarthropathy, including ankylosing spondylitis. Don't get caught. And you cannot make a wrong diagnosis if you basic principles of history taking. The person whom you are treating is a young man, 20, 30 years old. You don't get osteoarthritis at 20, 30 years old. And the person who is treating for the pain gets pain at night and early morning when he is trying to go for bath and toilet at night. Severe pains. And the same person, he takes his breakfast and goes to work, and whole day he works for 8-10 hours without pain. Comes back at night, again goes to sleep again. There is no other disease which can cause this except spondyloarthropathy. ESR will be high. Remember that. And remember only one thing, that usually you ask for X-rays of the spine. In this patient, don't ask for X-rays of the spine. X-ray of the sacroiliac joints, which is just one X-ray, plain view, PA view of the pelvis, which will show you both the sacroiliac joints. And if these joints are obscured, that is, this disease you must send to rheumatologist. So all these patients who are complicated in your practice, they should be sent to rheumatologists, not orthopedic surgeons. Orthopedic surgeons you send for operations, not for diagnosis. And then osteoarthritis of the back is very common, and the only thing is they can get a complication called as sciatica, and public is very afraid of sciatica. Let me tell you, sciatica is nothing else but same thing you get in the neck also. We call it a root pain. So you put a collar and all that and subsides, rarely surgery. But in the legs, when you get arthritis, arthritis is regeneration and regeneration. Body is the only machine where wear and tear takes place at the same time repair is taking place, which cannot happen like a motor car, for example. And when the repair takes place, you get these osteophytes. And if this osteophyte by chance presses on a nerve root, it will compress the nerve root, foraminal compression, and cause sciatica. So sciatica is a pain which goes down from the back right down to the foot. And this, for a very severe pain, of course, rest in bed, traction, injection, steroid again, very important. And the steroid you give transforaminal epidural steroid for sciatica, and give it by a specialist who is doing it under video fluoroscopy, the same machine for which you do coronary angiography and put a stent in the heart. Accuracy, look at the accuracy, putting a stent in the heart. That accuracy you need to inject here, then only you get a very good result. As far as possible, avoid surgery. I'll now show you a video. The diagnosis of sciatica is the patient is lying down straight. Suppose this patient has got pain in the back, which is radiating down. And if the pain radiates down beyond the knee, then you think of sciatica, because a lot of pains can backache can radiate up to here in the thigh. But suppose the pain radiates down here, 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 then we call it sciatica. Now, suppose the patient comes to you for pain in the right side. When you examine the sciatica patient, first examine the left leg, normal. You want to see how much can he do it. For example, you lift it, raise it and see does he get pain. He says he gets no pain. Now he knows what you are going to do and he knows he is not going to be stiff. And now you do the same thing on the side of the pain and see does he get pain. So when you start doing it, see does he get pain, can he do it, can he do it. If he can't do more than this, he says no, 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 so much pain, too much pain, too much pain. Well, that's a positive test. But in other patients with a mild sciatica, not a very patient may be able to do this much, but now he says he's got pain. Now he gets pain. And then what you do is to hold the hand like that and hold the foot like this and do like this, dorsiflexion what we call it. So when you do this, the pain increases. That makes it more confirmatory sign of a sciatica. So you have to do these things to confirm that this is sciatica. If this sign is negative, he can do full like that, complete without getting pain and without getting pain, there is no sciatica, finished, even if the pain radiates down. So when you finish the diagnosis of sciatica, the next question comes, he has gone to an orthopedic surgeon who says operation of the back. Now I want to tell you one thing, any patient of sciatica, before you, if you want to send him for surgery, you have to do only one test. Don't forget about the MRI, CT scan, X-rays, imaging. One test is that this is his big toe and all you do is to, he has got sciatica on the right side. Now tell him to raise your finger with force, हमारा उंगली जोर से दबाओ, ऊपर 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 दबा, जोर से और 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 जोर से. If he can do this, no operation, no surgery. If he cannot do this dorsiflexion against your resistance and he can't do it, most likely that patient may need operation. So this test of the toe, great toe, one test, plus some sensory loss may be there, may not be there, is very, very important test, in addition to of course a knee jerk, ankle jerk if you know how to take jerks, and then if you can, if the ankle jerk is lost, that's again a very good sign that this patient may need surgery. If it is normal, most probably he is not going to need surgery. So a sciatica patient should be treated with medical line of treatment. Don't hurry up for surgery because the results are very bad. 30-40% chances of bad complications after surgery. So this much about osteoarthritis. We now come for another disease. A GP, according to me, will see such a patient only once in a year. Only once in a year. And yet, what a beautiful diagnosis you can make and what a publicity you will get. Important thing is the publicity which you are going to get. That this patient, who is a middle-aged patient, 30, 40, 50 years, maybe 35, 40, 50, and who is usual businessman, high-class society people get gout, this acute gout attack we call it. Middle-class patient, poor patient, very rare. So such a man who is leading a very fast life and previous day he has gone for a party and drank beer and had a very chicken biryani and all that, comes and sleeps. He gets up at night at 2 o'clock to pass urine. And what does he find? He gets pain in this area. He gets sudden pain as if he has sprained. Then he tries to remember, did he fall down? Did something fall, hit him? Nothing. Nothing he can say. So he said maybe some strain, it will go away. He goes back to sleep. He goes back to sleep. It is 2 o'clock in the night. And by the time he gets up in the morning, by 6 o'clock, the knee, that area is swollen, red, very painful. And you can't touch it, so painful. It's one of the most severe pains. Acute gout, what produces one of the most severe pain. The patient can't put his foot down. Now he is a busy man. He has to again go to the office or a business and all that. But how will he put on his shoes? He can't even touch. How will he put on chappal? He won't be able to walk. So this severe pain has to be relieved very fast. Mind you, a pain of a gout, acute gout, we don't treat. Give anything, some ordinary painkillers. It will go. It will go. It will go, but it will take 1 to 2 weeks. 1 to 2 weeks for a businessman like him, this patient, is too much. So, and if you do the usual mistake, call an orthopedic surgeon, take an opinion of a specialist, because he's rich, he's big man. And I can tell you, anybody will be fooled. The surgeon will come and a doctor will, specialist will come and say, oh, joint is swollen. Oh, it's so tender. Oh, it is so hot. When you touch it, you say it's so hot. And even little fever, patient gets feverishness actually. So we must do a blood count, and blood count shows 25,000 leukocytosis. We say this is infection. He needs antibiotics. He needs this. Wrong. Everything wrong. Gout, acute attack produces all this which an inflammation produces, including low fever, including very high leukocyte count, and yet it is not infection. It's an attack of acute gout. And this person, all you do is give him, don't go for any test. Which test? Creatine, uric acid. No, uric acid during the attack can go down below normal also. Can be absolutely normal. So no investigation. Yes, if at all you want to investigate, you needle. Put a needle there, withdraw, and then again you will find pus, yellow. Again the surgeon will say, I was right, the infection. That yellow pus is not pus, it's uric acid crystals. You need a special microscope to see these crystals. If you are putting a needle, you might put steroid injection, hydrocortisone. Magic. Within few hours, patient will be relieved. But if you don't want to put an injection, needle there, 20 milligram tablet prednisolone, you get steroid. Steroid you get in 5 milligram, 10 milligram, 20 milligram tablet. One tablet of steroid 20 milligram for 3 days. First day, second day, third day. First day patient gets 30% relief, second day patient gets 60% relief, third day 90%, 100% relief. Finish. So, acute gout attack, you people are going to see maybe once in a year, and you must be missing it, I'm sure. It must be diagnosed as some arthritis. But if you have such a patient, you know what publicity you will get. That the specialist came and said it is infection, do this, do that, and you gave some pill, in 3 days, like magic it disappeared. And then of course, after the attack, you must tell him get your uric acid done. And if it is high, you don't have to start uricosuric drugs, you are in a hurry to start, like blood pressure tablets, start. What is the hurry? Because once you start the tablet, you will have to give it lifetime. So weight, first tell him reduce weight and no alcohol, especially beer, so you should never touch beer. No tobacco. And in the diet, vegetarian diet is okay, non-vegetarian, nothing wrong, but no fish, no red meat. This patient, surprisingly, many of the patients don't get the second attack. Very interesting it is. And some of them get the second attack after 2 years, 3 years. Again, only those patients who start getting attacks every 3 months, 4 months. That means 2-3 attacks in a year. They will need uricosuric drugs to reduce your uric acid, not otherwise. And by the way, we see a lot of gout in private practice, which is not this gout, which is iatrogenic gout. Moment the patient is taking anti-tuberculous drugs and he starts getting joint pains, you see uric acid 10, 12, 14, and this is due to your drugs. Many hematologists, when they give drugs, uric acid goes very high, 10, 15, 20. Then you need uricosuric drugs. That's a different thing altogether. It's not this gout which we are talking about. And then we come to another disease called frozen shoulder. Frozen shoulder is extremely common, and yet this is a disease diagnosed only clinically. No X-ray, no MRI, no CT scan, no blood test. It's a clinical diagnosis. You examine the patient's shoulder and do this abduction, and then you do external rotation. The treatment is physiotherapy, heat, and if the pain is very severe, local injection. I would like to show a video. I will now show you examination of the shoulder joint to diagnose frozen shoulder. Really speaking, you can see both the shoulders at the same time. So abduction like this. Moment the frozen shoulder starts, the patient starts getting pain, you will see that when you are doing abduction like this, the moment you come, he starts getting pain, then you more pain, and this pain on abduction is very important. There are patients you see in the clinic, you have been examining and you find they can't do more than this, but there is no pain. These are the patients of frozen shoulder who have not been treated well in the past, and the shoulder remains frozen permanently, which is bad. Now, once this test is positive, you are suspecting frozen shoulder. The next thing is to hold the hand like this, and now do like this, When this is also painful, very painful, it brings down to the pain, the diagnosis of frozen shoulder is finished. You don't have to examine anything more than that. All you have to do, the local tenderness, they will all have local tenderness, and that has got no meaning. But these two tests, once you do, frozen shoulder is excluded. You don't have to do anything more than that. The same thing can be done on this side when you do, after doing this thing, when you do like this. This is the examination of frozen shoulder. If the pain in the frozen shoulder is severe, very severe, the treatment is to give local injection of steroid. So often these people are mild diabetics and all. So even then nothing wrong. Only severe diabetic patient, not controlled sugar, you cannot, it's not safe to give injection. But otherwise the treatment is to give a local steroid injection. And I want to tell you that please don't send these patients for injection to orthopedic surgeons. Send them to a sonologist, because the local injection done by a sonologist is not helpful for you. These sonologists, when they do sonography of the shoulder, it's a beautiful investigation. I mean, somehow GPs have not become fond of it and doctors are not asking for it. Very sad. X-ray will show you nothing, CT scan will show you nothing. But if you do sonography, you see the advantage is what? I'll show you. For example, if it is adhesive capsulitis, that is actual frozen shoulder, the sonologist can give the injection in the right area under the machine. He is looking at it and he is injecting. And by chance, if he sees bicipital tendinitis, which is here, this groove, that also pain is like frozen shoulder, then the diagnosis is wrong. Diagnosis is bicipital tendinitis, then he will inject steroid in the bicipital tendon. And sometimes supraspinatus tendinitis, this muscle tendon, there is calcium deposition, that's causing this frozen shoulder. Then what he has to do is he just takes a needle and removes calcium. Finished. The pain is gone. So you can see the diagnosis and the treatment both by the sonologist. And lastly, sometimes your diagnosis is wrong and it's a tear of the rotator cuff, one of the tendons of tendon or rotator cuff are like this. They can all be seen beautifully under sonography. And if there is a tear, that patient needs operation, surgery. So wrong diagnosis. So the sonologist is very useful. He can pick up your wrong diagnosis. He can inject the other differential diagnosis condition which act like frozen shoulder, and finally he can give a proper injection in this frozen shoulder. Now we come to another condition called rheumatoid arthritis. Rheumatoid arthritis, you people are going to see once in maybe 2 months or 3 months. So it's not an uncommon condition. Please remember that. The only arthritis which is most common is the rheumatoid arthritis, which is not a wear and tear, an infection, autoimmune infection. And all GPs should treat rheumatoid arthritis. They should not be sent to rheumatologists. For rheumatologists are meant to help your patients with rheumatoid arthritis who have got complications. How do you diagnose rheumatoid arthritis? If most of the time it's middle-aged person or an elderly person, middle-aged woman or something, is more common in women, they start getting pain in the hands, in the wrist. And remember one thing, it's a bilateral disease of both sides, not symmetrical, but bilateral. One joint here, one joint there. The joints start paining early in the morning again, and with the pain, the morning stiffness, they become stiff, fingers become stiff. The stiffness lasts for about 1 hour, sometimes half an hour. Remember that all osteoarthritis and other illnesses, there is stiffness early in the morning, but 5-10 minutes, not half an hour, 1 hour. If this patient has got at least 3 joints involved, diagnosis can be made very fast. If 5 joints involved, 1 second diagnosis. So you have to see for diagnosis the hands and the wrist, because from there you will make a diagnosis. And the diagnosis is in these joints of the hands. Once you have made this diagnosis, I will show you in a minute. Once the duration of the illness is 2 months, you can close the chapter and say this is rheumatoid arthritis. I would do it even at 6 weeks. Patient is suffering, pain early in the morning. Why is this duration mentioned in the books for diagnosing rheumatoid arthritis? That you wait for 2 months, 1.5 months before you make a diagnosis? Because the viruses like chikungunya can cause same joint pains. You can make a wrong diagnosis. But in my opinion, it's very difficult to miss chikungunya. Chikungunya, first of all, people who come for chikungunya come from localities where they have heard the name of chikungunya. They know what is chikungunya. And when, like dengue fever, they get acute fever with joint pains, multiple joint pains. Don't treat a patient with chikungunya because they will not respond. There is no treatment. You shouldn't have a patient with chikungunya if possible. So it's not a good disease, and yet it's not rheumatoid arthritis. Anyhow, the point is, if you have slightest doubt, you do a blood test. Blood test of chikungunya is available. If it is negative, it's not chikungunya. Finished. If it is not chikungunya and 6 weeks have passed and these symptoms are going on, clinically 100%, and you take the advantage of your tool, what tool you need for rheumatoid arthritis? First tool is your fingers when you are examining the patient, and the next tool is ESR. ESR is high, your finger tests are positive, diagnosis rheumatoid arthritis. Finished. You cannot go wrong. And the patient complains of, say, pain in one metacarpophalangeal joints and proximal interphalangeal joints, not the distal ones, not the far. These joints, these joints. The pain and swelling and everything occurs in these joints. So examine these joints carefully. Now she says there is a little pain there. So press it and see if she is tender there. There is a little pain. Press it and see if it's tender there. Similarly, examine the wrist. I'll show you a video. The diagnosis of rheumatoid arthritis is made only from here. You don't have to examine the whole body. You don't have to examine the rest of the joints. The diagnosis you will be made by examining only this portion of both the hands. Now, wrist joint, metacarpophalangeal joint, and the first interphalangeal joint. These are the joints which are affected on both the sides, but not all joints, not bilateral symmetrical. Maybe one joint here, maybe one joint here, maybe one joint here, maybe one joint here. So if you have about 4 or 5 joints affected, the diagnosis is 100%. Patient complains of pain, and you must note, if he complains of pain in the wrist, you can positively ask for that. He complains of pain here or here. Now you want to examine. So for example, you start with metacarpophalangeal joints. So each one of these joints you press like this. You press like this. You press like this and ask for the symptom of pain. If the patient gets pain when you press, we call it tenderness. So the symptom of pain, symptom, and the eliciting this tenderness will complete the diagnosis of inflammation of the synovium. Synovium is the covering of the joint, which is affected in rheumatoid arthritis and autoimmune reaction, autoimmune inflammation. So once you elicit a tenderness, it's a very important physical sign confirming the diagnosis of your arthritis. Now after you finish these joints, then you come to interphalangeal joints. First interphalangeal joint, press here, press here, press here, press here, and here also. So if you have in rheumatoid arthritis, the joints which are affected are this and this, plus of course maybe wrist also, but not these joints. not these joints. These joints are not affected in rheumatoid. These joints are affected only in osteoarthritis in old women. So, important thing is this joint, you look, is there any swelling? If there is a swelling, additional sign of inflammation. So, tenderness, swelling, pain in 1 or 2, 3 joints, and then you go to the wrist, and wrist you press like that here. If there is any tenderness anywhere in the wrist and the patient has got pain, especially early in the morning with a little stiffness, this is synovitis of rheumatoid arthritis. If you see the old patients of rheumatoid arthritis of say 6 months duration, not treated well, you will always find the wrist becomes big, synovium becomes thickened. So, wrist is a very important part of the hand to examine. So, one hand, then the second hand, and this is the examination for rheumatoid arthritis. So, you can ask for anti-CCP test, but most important ESR will be high, and the distal interphalangeal joint which I was talking you, and that arthritis is a different type of arthritis. It's found in some women, and there is a little nodes there, and you can have even little deviation of the finger, but there is not severe pain, no treatment required. So, rheumatoid arthritis is a clinical diagnosis. You, all of you must become confident of treating it. It's a medical emergency. If you don't treat fast, then the fingers become teda. So, all these teda fingers which you used to see in the past are because of wrong treatment, late treatment. Treatment should start immediately. It's an emergency. Otherwise, fingers will become like that. And what is most important is we give them polytherapy. What is polytherapy? Not one drug, 4 drugs, 5 drugs. Tuberculosis, why don't you treat with one drug? Only isoniazid, only rifampicin. No, we'll give 4 drugs. We'll give 5 drugs, 6 drugs, MDR tuberculosis. So there are certain diseases where you need multiple drugs. That's called polytherapy. And then lastly we come about steroids. Steroids are magic drugs, rheumatoid arthritis, and doctors misuse them. And if you use it wrongly, you will have problem later on. Because you give them steroids, they improve so dramatically. So, the treatment is not to give steroids. These are the 4 drugs which are the best drugs for rheumatoid arthritis. Methotrexate. You should become friendly with methotrexate. I find in the last so many years, GPs are very afraid of methotrexate. But methotrexate and biphosphonates, alendronate, what is the difference? That also you give once a week. This also you give once a week. But don't be afraid of this drug. And the small dose of 7.5 milligram with 10 milligram is wrong dose. Minimal 15 milligram. Minimal. Average hefty patient and all, hefty lady and all, 20 mg. Once a week, just like alendronate, but you have to also give folic acid because it consumes folic acid. 1 tablet. HCQS, you have been hearing it in the nowadays in the corona epidemic. It's a very safe drug. Please remember, we give them 200 milligram twice a day, maybe 1 year, 5 years, 10 years. Nothing except once a year you check your retina. No side effects. Leflunomide, another drug, salizopyrin, 1 gram twice a day. Salizopyrin is a safe drug. Or your patients of ulcerative colitis, we give salizopyrin lifetime, 1 gram twice a day. What are you afraid of? The question is prednisolone. It's a magic drug. You give it terrific relief, but diagnosis will go wrong and the whole thing goes wrong. Best thing is, please take my advice. explain to the patient that this is your main drug, methotrexate. Please explain to the patient. Methotrexate has to be taken for 1 year, 5 years, 10 years, I don't know, maybe longer. Once a week the patient should take the drug, and every 3 months we do one test for liver, one for kidney, one for marrow. But most of the time, very little. By chance, if you find something abnormal, reduce the dose, otherwise not. But the trouble about methotrexate is the best drug for rheumatoid arthritis. Trouble is, it takes 2 months to work. 2 months to work. Now you don't want the patient to suffer for 2 months, and you'll lose the patient. He'll go away to some other doctor. So therefore we give them prednisolone. Explain to him, I'm giving you magic drug, fast relief, but for 2 months, not more than that, because by that time methotrexate takes effect. So start with 20 milligram. Taper the dose as soon as within a 10 days patient feels alright. You will be surprised. Beautiful. But what is working is not this. This is working, but we don't want it to continue. By 8 weeks, this takes up. By now, you don't need prednisolone. These drugs you can continue maybe for 1 year, 2 years, 5 years, depending on the different patients. So this finishes rheumatoid arthritis. And now, before I finish, I want you to believe in God. God sends you patient. God sees that patient will respond, that patient will not respond. So please pray God that once a year, a very rare disease, when God should send you a patient of Polymyalgia rheumatica, PMR. Beautiful diagnosis for a GP to do. Best specialists will not be able to diagnose this. These patients are suffering at the hands of the specialists. These are elderly people, 70, 80, 85. This disease doesn't occur at young age, middle age. And there are no tests to confirm this disease. The only test, which I will not call as test, is your ESR. If you have this ESR with you, and when you find that ESR, and elderly people, the normal ESR is up to 30, 35, remember that. So it has to be more than 40. So when you find 60, 70 ESR and you have diagnosed this, then your diagnosis is correct. So what is this disease, Polymyalgia rheumatica? This is a disease where elderly person who has already got possibilities of all those 3 illnesses which I started with the whole lecture. 75 years old lady, she's already got a man. He's already got osteoarthritis all over the body. He already must be having osteoporosis, some fractures in the vertebra. And the patient, he's also got osteomalacia, vitamin D deficiency, not going. So whatever pains this patient goes on getting are being attributed to this. And the patient is suffering. Suffering with what? The pains. And pains, the diagnosis should be made if you pick up this patient. The symptoms are bilateral symmetrical. That word is very important, bilateral symmetrical. So when they get shoulder pains, for example, at night and early in the morning again, it's bilateral. Both the shoulders in the morning, they can't open the door, geyser, switch. In the morning they can't do it. So severe pain, both sides. And by the time passes, by afternoon, they're better. By evening, they're better. Again at night pain here, then pain in both the neck muscle, both neck muscles, severe pains. And the pains in both the thighs and the whole pelvis. At night, they can't take turns. Maybe such a severe pain. And early in the morning, it was so difficult to sit in the commode, to take a bath, to put on the clothes. As the day passes, they become better and better and better. That should give you a hint. This could be Polymyalgia rheumatica. And all you do is ESR, nothing else. ESR is 60, 70, 80, 90. Finished your diagnosis. And now you do this magic treatment what I call as therapeutic test of steroids. The same 20 milligram tablet. I told you in gout how you use it. I told you how you use it in rheumatoid arthritis. Now see how you use it in this disease. You take a tablet of 20 milligram of prednisone. Give that patient one tablet daily for 3 days. You cannot believe this lady who had not walked for weeks together, with your first tablet 20 milligram one day, she starts standing up, sitting up. Second day, 60% relief. She tries to go to bathroom. Third day, she is walking. She is walking. This is a walking publicity for you. To have a patient like that, the whole chawl will come to know. The whole building will come to know that this patient was suffering. This patient could not walk. This patient could not sleep. And this patient now walking 3 days, and preferably keep tablets with you and give from your pocket. 3 tablets of prednisone. This is called therapeutic test. If it works like that, your diagnosis is correct. If it doesn't work, 100% diagnosis is wrong. And if your diagnosis is right, then of course a little problem. Problem what? That this patient will need a small dose of steroid of 5 milligram for 2 years. At least 1 year, maybe 2 years. So you have to taper off the dose and bring it to 5 milligram. And during this 1 or 2 years, you will have problems about acidity, because already an elderly person, blood pressure, diabetes, you have to look after naturally. And most important, osteoporosis. She is already osteoporotic. You are making her more osteoporotic. So every 3 months, your DXA study should be done. And don't hesitate to start biphosphonates, alendronates. Maintain for 1 year. After 2 years, that is the story of polymyalgia rheumatica. Please pray God that once a year, it's a rare disease, you should get one patient of that, which will be walking publicity for you. Thank you. Good.